next and last presentation in this session is Implications for the Research Enterprise, and our presenter is Ann Bonham, who is the Chief Scientific Officer at the Association of American Medical Colleges.
So thank you to the IOM, to the Planning Committee, and also to my colleagues, Andy and John and Lewis, for their thoughtful comments, and also for my AMC colleagues and policy team, Heather Pierce, Steve Heining, Anu Deb, and also Anne Berlin. So I'm going to give maybe a 10,000 or 30,000 foot view, but fundamentally there is a lot at stake here. And the discussions that you all have had in this room both yesterday and today can and probably should launch a further national conversation and perception on how we should move forward to ensure the longevity of research on standard of care or medical practice, and at the same time ensuring the reasonable, meaningful participation of engagement of patients and subjects in research. That is a very challenging thing to do, and we've been struggling with it, as we've heard from some of our previous speakers, now for probably close to 40 years. So keeping that in mind, I had 4 observations and comments. And the first one, that all of us, researchers, clinician researchers, and subjects, and the public should be very candid about our own perceptions and biases of when the evidence is good enough and when it is not. The more we separate and polarize evidence gathering from clinical judgment, and John said it very eloquently, the farther away we get from coming to some resolution that will advance research that is going to benefit patients today, but also future patients in the next decade. Now, recognizing that the draft guidance is what it is and really concerns research, there is a larger principle at stake, which many of you have already talked about, and that is that maybe this discussion should go back and inform a morally informed consent process for how we deliver care and practice medicine. And if we can use the discussions about the draft guidance to launch that national conversation and begin to change that practice, it seems to me that in future, draft guidances like this may not be necessary. Finally, we know now, and I think we have heard this from many of you, that the standard of care may vary depending on who you are, your race, your ethnicity, your sexual preference, your religious, where you live, who you are, and who and how you are perceived. So I think taking that into account, we need to understand that there is not one single standard of care perceived or experienced by all, including the vulnerable populations that Lewis referred to. Moreover, a standard of care is not perfect, it's not permanent, and in fact the goldness may be not so gold. So because it is dynamic, it seems to me that the whole point of establishing the research on care is to advance and elevate that standard of care, which may change and probably should change in the next 5 years or the next 10 years. So these are the opening comments that I'd like to sort of set the groundwork for making 5 points in considering how to address the draft guidance, but also maybe going a little bit beyond that. Number 1, the outcomes of this discussion should be targeted to helping OHRP develop clear, precise language that leads to a fairly consistent, predictable action by investigators, IRBs, clinicians, and regulators. And this clarity and precision is so that it can give confidence to investigators, whether they're in New York or Ohio or Arkansas or California, that there is guidance that is fairly simply interpreted by all, so that it is not a free-for-all, but there's some narrowness in the understanding. Now, by narrowness, I'm not really thinking about rigidity here, because it's very clear that depending on the research, there is not one size guidance that fits all. but there has to be confidence in how we interpret the guidance so that investigators don't feel like at the end of the study there is a gotcha when they think that they have followed through the intent and the content of the guidelines. This will not be easy, and it was suggested yesterday by some that maybe the lack of coming to an agreement around the interpretation of the draft guidance would send an important message. Frankly, I'm not so sure. And I would suggest that not having clarity around the draft guidance in the language could result in unnecessary anxiety and unease, both on behalf of patients and subjects and researchers and clinicians and all other stakeholders. And in the end, that has some untoward consequences. It certainly limits innovation. We know that. It certainly limits the engagement, meaningful engagement of patients and subjects in research. And in the end, that will not be advancing care over the next decade. Second point, OHRP should provide additional guidance on the process. And by the process, I'm talking about that process that's used to determine first the risks of research in the purview of the IRB, and if the risk is foreseeable, should be disclosed to the research subjects. So again, I go back to the institutions and investigators and indeed subjects need to have confidence in what processes and systems are sufficient and how the determinations of whether those processes are sufficient are determined. So for example, who has the ultimate responsibility for assessing whether the proposed risks that are to be disclosed are the right risk, the risks that are material and that matter to that patient or subject that was pointed out previously. Patients, in my view, and research subjects are fairly and very capable of identifying risks which are important to them. And shouldn't that be what's important in the context of the guidance, what's important to them in the context of their lives, their health, and their disease? Whoever decides the decision, and Jeremy pointed this out, that decision should be based on the volume and credibility of the available evidence, which should take into account the frequency, the magnitude or the severity and the context of the risk. And John sort of made that point of the threefer, the two most frequent and the one most important, talking about the risk and the benefits. Third point, OHRP guidance should be clear that the information that the individuals need to decide whether to participate should go beyond the risks. This was made many times yesterday, and I think it's an important point to consider in commenting to the draft guidance. And as Jeremy pointed out yesterday, risks are not harms. They are the chances of harm. But there are also benefits, and those should be part of the guidance so that people can not just look at the risk, but also look at the benefits and weigh those risks and benefit. And that was eloquently pointed out by a patient representative who spoke yesterday. And the worry is, with this sort of focus on risks, it could lead some IRBs to really think about their goal. The take-home message is to greatly expand the risk section of research. Now, realizing I'm speaking to the choir, nonetheless, I think there is a risk that there will be some IRBs that might have that as a take-home message. Fourth point. It seems to me that we have learned a couple of other lessons, and that is from the presentations from the research both yesterday and today from UW, Duke, Penn, and Brigham, that we should be very proactive. The community should be very proactive in doing research and obtaining data on how patients and subjects interpret risks and benefits and information sharing and how they're engaged. And I think sort of not engaging in that research is really on us. And that can influence the next guidance that comes down the road. And wouldn't it be special if there was an evidence-based guidance in the next iteration of this? And finally, the guidance, as eloquently stated by more than one patient voice, should embed the engagement and voice of subjects or patients, not just protecting them or shielding them. So maybe the conversation that we have here should be framed from the vantage point of meaningful participation of patients as partners and part of the process. The informed consent document, which has been, this point has been made before, should be a reflection of the conversation that takes place, not a substitute for it, and it should be part of the moral consent and information commitment that we have, whether or not the research tag is attached to how we approach our patients and provide care. And finally, I think this notion of engaging patients in peer-to-peer consent cannot be ignored. And also, finally, we need to engage patients so that they have some comfort with living with some ambiguity, because there is always going to be some ambiguity. And I think that thinking about the willingness and the sophistication of the patients, helping them understand the ambiguity can be most helpful in this. And finally, I think recognizing that there is altruism, and that in John's case, recognizing that it is our moral obligation that researchers, clinicians, patients, subjects all have some degree of altruism, and the guidance should in no way minimize the altruism that I think makes us do what we do and care about what we do today and in the future. Thank you.
Any questions, comments for Anne? Okay, if not, I'm going to turn it over to Celia Fisher to lead us through the panel discussion.
Okay.